Good afternoon, and welcome to today's program, Treating for Outcomes or Better Care, Understanding the Excellence in Mental Health Act. I'm Julie Miller, Editor-in-Chief of Behavioral Healthcare. Today's program is sponsored by Echo Group. Thank you to our sponsor and to everyone in our audience for giving us your time and attention today. Before we get started, we do have a few details that we would like to review. You'll notice that each window on your screen can be moved by clicking and dragging, or you can enlarge and minimize by clicking on the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. You don't have to wait until the end of the presentation. But if you can't see this area, simply click on the red Q&A button. To download a copy of today's presentation, please click the link in the Resources area in the lower left of your screen. And if you have any technical issues during the program, please just click on the yellow Help button, and we will definitely help you troubleshoot the issue. Finally, you can also tweet during today's webinar using Twitter. Just click on the blue Twitter icon at the bottom of your screen, then click the Post and Authorize buttons to log into your Twitter account and begin sharing automatically at the event hashtag BHLiveWebinar. At this time, it's my pleasure to introduce our speaker for today, Sookie Norris. Senior Knowledge Engineer Sookie Norris is celebrating 20 years with the Echo Group and has more than 35 years of experience in healthcare, including healthcare law, managed care, and behavioral health. Sookie also has extensive experience with Medicaid waivers, meaningful use, and the Excellence in Mental Health Act. She's worked extensively in data analysis, including analysis of big data in support of clients and ongoing research. Her knowledge of behavioral health law has been sought by customers across the country as they address specific needs, such as electronic health record implementation. Thank you, Sookie, for taking the time to speak with us today. And with that, I'll turn the audience over to you.
Thanks very much, Julie, and welcome. So today what I want to talk about is the Excellence in Mental Health Act, but from a little bit different perspective. And that's the perspective really twofold. Not everybody is going to be a certified community behavioral health center, but everybody can my premise is that everybody can benefit from the discussions of workflow and quality that are part and parcel of the Excellence in Mental Health Act. Today what we're going to do is we'll do a little overview of the Act, and then we're going to look at the assessments, the quality measures, and the outcomes measures and other related items that are all a part of the Excellence in Mental Health Act. And before I get started with that, I just want to sort of set the groundwork, and that is that if we look at mental health right now, prior to the Excellence in Mental Health Act, even though there's a SAMHSA, even though there's a CMS, the reality is that there are really 50 different departments of mental health, each with their own concept and their own ideas of how mental health services, behavioral health services, should be provided as to quality, as to programming. And that meant and means that depending on the language you speak, depending on your location in the country, the services that you receive can be quite different and really can vary even in a given state, in some states as small as New Hampshire or as large as California. So the Excellence in Mental Health Act really represents the first time that the federal government has created a law specifically addressing behavioral health concerns. Now, other times there have been, behavioral health concerns have essentially been square pegs in round holes when long-term care is addressed by the government, or perhaps medical care or hospital care. It was part of the Protecting Access to Medicare Act, and the section specifically addressing the Excellence in Mental Health Act is Section 223. And that section established a demonstration of programs to improve community behavioral health services based on a preset of criteria: staffing, the availability and accessibility of services, care coordination, which is a core element of the Excellence in Mental Health Act, a scope of services, quality and other reporting, and organizational authority. And oftentimes you hear the reference to CCBHCs, and that's because those participating behavioral health clinics that participate in this Section 223 will be known as Certified Community Behavioral Health Clinics or CCBHCs. If you look at the criteria, you start to see what I was referring to earlier, and that is the desire to create a consistent delivery of services across all 50 states. Because staffing is discussed. Staffing can be varied, but under the Excellence in Mental Health Act, that staffing really needs to meet certain criteria, certain elements to be able to be a certified behavioral health clinic. The array of services are services that may not be available in every area, but what the Excellence in Mental Health Act is saying is they should be and they need to be. Maybe not every area has services designed to address military personnel. But is there any place in this country where there shouldn't be services that address the needs of the military? Just an example. But today what we're really going to focus on are the elements of quality and other reporting, and somewhat the elements of program design that feed into quality and other reporting. So the first thing we're going to look at is required timeframes. And as we look at these things, and as you're thinking about CCBHCs, also think about your own agencies, about how you look at your goals for providing care to your clients, the goals that your agency might have for service delivery, for quality elements, for those kinds of items, to see that while some of these may be prescripted by the law, they also make good sense for just the development of your own program and the own program guidelines. As an example, if somebody comes in requiring emergency services, those have to be provided immediately. Probably not any change from any of the things that you folks do now. Urgent has to be done in 1 business day. And maybe you're not always able to meet this deadline, but I would guess that it probably is a goal for your agencies. And then routine, and this may be a little bit different for some agencies, routine has to be addressed within 10 business days of the initial access to the CCBHC. The next item is the comprehensive person-centered and family-centered treatment planning has to be done within 60 days of the first request for services. 2 things to point out here. There is an overarching focus on person-centered and family-centered services. That really what the Excellence in Mental Health Act brings front and center is the goal of person-centered planning, of person-centered care, that the client, that the person is at the center of all the services that they need and controls that universe. It is their universe to really determine and to work with their clinicians to get the services that they need. And because it's the continuum of age from 0 to old age, it's family-centered as well, because oftentimes these consumers come from families. And it's not just enough to make it consumer-centered, but it is the family that is suffering from the challenges that are being faced. And it is the family that has to be at the center with the person to ensure that the care that's being given addresses the needs that are being presented. Outpatient clinical services for established consumers have to be within 10 days of the requested date. Probably a need to kind of move many agencies towards open access or immediate availability, because oftentimes you may not have staff available within 10 days. But there are specific staffing requirements to try and get to this goal, as well as quality requirements that you meet these goals. And the final one, which speaks to, again, I think, person-centered, is the absolute goal that you do everything you can to contact a consumer who is discharged from a hospital within 24 hours of discharge. Now, the rules contemplate that that may not be possible, but the goal is that you as an agency would do what you can. And again, whether you're a CCBHC or a behavioral health agency, being in touch with folks who go into the hospital gives you the greatest opportunity to keep them from having to go into the hospital again. Today we're really going to focus on quality outcomes reporting, so I thought I'd just give you the language from Section 223 that specifically addresses, so you get an idea of just how broad in scope it is. The statute requires that there be published criteria to include the reporting of encounter data, clinical outcomes data, quality data, and such other data as the Secretary requires. And if you're looking to be a CCBHC, what this tells you is you better review your state's plan, because the states have leeway in determining what outcomes are required, what elements they're going to be looking for. But if you're looking at this as sort of an overarching design or redesign of the behavioral health system, then as you'll see in a little bit, guidelines are provided and information is given throughout the CCBHC enabling proposals that really give you an idea of the kind of quality elements that you should be looking for. So first, assessments. And assessments in the Excellence in Mental Health Act really follow various areas. They are diagnostic assessments like mental status exams or biopsychosocials. And they can be, sometimes they're prescribed, sometimes they really just speak of diagnostic that includes such things as employment and living situation, and all the kinds of things that any of your agencies may probably are collecting within a biopsychosocial. But then they specifically say you have to have depression screenings, the PHQ-9. And it is true, I think, in current methodology that more and more agencies are using the PHQ-9 both in their mental health practice and their substance abuse practice to keep track of just that depression screening, so that is something that's part of the electronic record. But here it really must be followed, and there again, while it's something that the Act is saying, it is not outside the bounds of really good and I think appropriate clinical practice. Also, it speaks of standard assessments. I know that in some proposals they've said they're going to use the GAD-7, but what they're looking for in standard assessments is the ability to collect data across multiple agencies that all is based on the same set of structured data elements. So that's why we're looking at standard assessments, because they're structured, and you can not only look at it within your population base, but it gives the state and or the federal government the ability to start looking at data across all areas to ensure this concept that wherever I live, whatever language I speak, whatever population I'm a part of, I'm going to get the same quality of care, the same type of care. And then the assessment of imminent risk, or the lethality assessment. And again, I'm pretty certain that many of you do this. I worked for a behavioral health company many years ago, and this was the first thing that any phone screening did when somebody called for work for a managed care company. There was a screening done to make sure that the person was not at risk. So you get an idea of the assessments, and the assessments are really within each of the items. Within the service array, there's a service array that specifically deals with sort of assessment and diagnosis and treatment planning. And that's really where you're going to find this information. The next element are the quality measures. And there are many quality measures. And let's look at what kind of quality measures that they're looking for. If you currently a test for meaningful use, you're going to see many of these quality measures in your current practice. If you don't attest for meaningful use, perhaps you get PQRS or Medicare dollars. Again, you'll see these kinds of quality measures within that set of data requirements. And this may be the place where I really would focus on the concept of, are you treating for outcomes or are you treating for better care? Because if you look at some of these, you'll say, wow, they're really looking at my outcomes. They're not telling me anything about care. But let's just start with an easy one, not an easy one, but one that I think speaks to both worlds. The number of suicide deaths by patients. I am certain that in each of your agencies, you know just how many people would fall into this category. So the question is, why is this a quality measure? Is it a quality measure because they really want to, one, keep this number down low, which I would attest is something every agency is interested in doing? And or is it a quality measure to be able to track, just as we track population health? Do people who are watching this at a higher level need to see where there is a higher incidence of suicide? Perhaps not because the agency or the CCBHC is having problems. Perhaps it tells something about what's going on in that area or the age group that's happening. It gives the opportunity, as most of these quality measures will do, to give you, the agency, something to look at that I think is a true quality measure, an important element of your review of your own practices, and gives the government, whether it's state or federal or regional, the ability to look at data across multiple areas to see if there are elements that need to be addressed. It's really, I think, similar to other kinds of screening that are now done with population health and with the advent of computers and the ability to review and to analyze big data. We're able to see trends where otherwise it was anecdotal. So one of the things that these quality measures are doing may not be to tell you how to practice, but to say, if you are having these problems and someone else is, what can be done to help us address those and reduce them for everybody? The concept, issues like the number of % of clients requesting services determined to need routine care. One of the first slides I showed you said if it's routine care, it needs to be provided within 10 days. This is just, and perhaps we can all agree that that's a good standard. If we do, then while this might be a federal measure, it's also one from an agency standpoint that's important to look at, because it means that people are coming in and getting the services they need in a timely fashion. Across the country, when this was seen as getting out of hand, people addressed it. How did people address it and are addressing it? By open access. They realized that those appointments weren't getting kept, and two, weren't being able to be made. By open access, they were able to really shorten that time, oftentimes to below 10 days. But if you aren't tracking it, then you may not know, except again anecdotally, that there's a problem. Why is it important for a treatment plan to be done within 60 days? Because I think back in school we learn that the services that we provide and what we provide our clients, especially in a person-centered world, ought to be what they need to reach the goals they want to reach. If I don't have a treatment plan, then I haven't given my client the opportunity to really convey that information to me. Again, this speaks to the goals of the Excellence in Mental Health Act, but it has a larger context, I believe, in everybody's behavioral health agency, because it is what you're trying to do. You're trying to ensure that all services provided meet the needs of a treatment plan. And even if you're not, and that's always been a point of a Medicaid audit, but even if you're private, even if you're a private behavioral health agency receiving money from insurance companies, you're asking for authorizations based on your treatment plan. you're providing services based on treatment plan. And this really just speaks to the integration of that with what are the federal goals of the program. Documentation of current medications in the medical records. In this day and age, a medical record wouldn't be complete without current medications. In addition, it's part of meaningful use. But of course you're going to want to know, because as you treat somebody, whether or not you need, how often they need blood tests, those kinds of things, are fully dependent on the kinds of medications they're taking. So again, it may be a quality measure, it may be something that's being tracked, but it also can be something to remind the agencies of the kinds of things that they want to track. And the final one on this slide I want to talk about just a little bit, and that's preventative care and screening. Why is this part of the Excellence in Mental Health Act? Because part of the Excellence in Mental Health Act is integrated physical care. Because if you're doing person-centered planning and you're treating the whole person, understanding what their physical needs are is important to meeting the goals of their mental health or behavioral health needs. So within this, there is a desire that you take blood pressure, you take height and weight when somebody comes in. And then you're going to see if there are issues. Maybe those issues require you to recommend you to refer them to physical health. Maybe it's something that clinicians can deal with. In the Excellence in Mental Health Act, that's part of the treatment that a client is supposed to get. But is that really something that should just be in certified behavioral health clinics? Isn't that something that, given the right tools, can be done in most agencies and people would benefit from? Similar, which you'll see again, smoking cessation. Nobody thinks that smoking is healthy, so if your client is smoking, maybe it is something that can be addressed. Controlling high blood pressure. I will say that there are a lot of reasons to control high blood pressure. Let's start with the easy one, in that, again, Excellence in Mental Health Act says it's an integrated care. So if somebody has high blood pressure, it's important that they get and are treated by a physician. What are other reasons? Well, I know, too, that if a physician is treating high blood pressure with medication and the behavioral health entity is treating the client with medication, understanding those medications, knowing about those medications, that medication list we saw before, it's important. Secondly, high blood pressure it can be scary. High blood pressure can be dangerous. High blood pressure can have issues that really are related to the health care, but really speak more to how the person is responding to it. If I'm doing person-centered care, whether in a CCBHC or outside, this is something that probably the primary health care provider and the behavioral health provider can work together to help the client with. Maybe to reduce the blood pressure, maybe to help the client understand the issues with blood pressure and address any of those that can be addressed, even if only the fear of high blood pressure. Screening for clinical depression. Well, the clinical depression, we talked about the PHQ-9. If you're going to do a PHQ-9, then then the opportunity to screen for that depression and what's found, and keeping in touch with the client if the PHQ-9 indicates depression, makes good sense. I wouldn't do a PHQ-9 and just leave it sitting there. So this really just speaks to practical process that would happen after using an assessment such as the PHQ-9. Initiation and engagement of alcohol and other drug dependence treatment. The Excellence in Mental Health Act is not just about mental health. It also requires the CCBHC to address the substance abuse related issues. I live in New Hampshire, and this is certainly an issue in our state and in most states. Treating these providing an opportunity for people to get alcohol and other drug dependence treatment wherever they live and in whatever manner they need is critical to addressing some of the most frightening, I think, issues for us today in healthcare. If you're a behavioral health agency and do not provide drug and alcohol services, it's still important because wouldn't you want to know that there is a fixed entity you can refer these folks to once you find out that there's a problem? Don't you want to know that there is the breadth of services, something that the Excellence in Mental Health Act is getting towards, to provide that breadth in services so that those services can be provided at the time and where they're needed? The suicide risk assessment. It is important, if we're going to track suicides, that we also look at suicide risks. But it's not important because we track suicides. That may be why it's there, because of the Excellence in Mental Health Act. It's important because we're a behavioral health agency, and if we don't track suicide risk, there is no place for suicide risk to be tracked. So again, we're looking at these quality measures that are very real, they are federally identified, but do they really require a change in the method by which you provide services, or do they just give you an opportunity to look at those services a little differently? If you're going to be a CCBHC, this is your world. But even if you're not, is there a reason why looking at these kinds of measures and participating in this portion of it won't provide you with an opportunity to continue in that care that you're providing? Maybe not to improve it, but to enhance it. Everybody does the best they can, but this federal legislation, the first legislation ever to look at behavioral health, is giving people ideas on how to extend and improve the way they provide services. Now, I've put in this slide deck all of the quality measures. I may not talk about them all, but they all are here. Diabetes screening for people with schizophrenia or bipolar who are using, there's so many reasons that this is important. The medications are the starting point because those medications can cause contraindications, but also because these are people who may not see the signs in themselves. Their illness may be such that it precludes them from seeing the physical manifestations that a person who does not suffer from schizophrenia or bipolar would see, would know to go to a doctor and ask those questions. Maybe this isn't the reason that people with mental illness die 25 years earlier, but it's part of that. If my illness keeps me from seeing my physical challenges, I need help. In a person-centered world that focuses on integrated care, which is not just for CCBHCs, that's the help I get from my providers. And they have medical folks that they can talk to and have a conversation to get the kind of care, to get me the kind of care that I'm going to need in this situation. It's easy if a person has Alzheimer's that we know they don't know when they're sick, because they just don't know. But we have to understand that people with mental illness may have the same blocks. They may have the same blindness for illnesses that other folks would see immediately, be it flu or pneumonia or diabetes. Metabolic monitoring for children and adolescents on antipsychotics. I would bet that most every psychiatrist who prescribes antipsychotics is doing some sort of metabolic monitoring. But on the outside chance that they're not, this just reminds you, wherever you are, wherever you're doing this kind of prescribing, that has to get done. Maybe you're working with a doctor and they're doing it. This is just a reminder to the doctor that that's part of the program if you're going to prescribe those kinds of drugs. Again, just to sort of bring us back, the idea being that while these are quality measures specifically designed to specifically addressing the CCBHC requirements, they don't require the programming that they require, the processes that they require aren't done because of them. They're done because we provide behavioral health services, and if we provide those services, these are good and smart outcomes to look at. These are good and smart quality measures for us to consider as we design our programs, as we change our programs, as we modify, as we look at a constant evolving of our products. Following up after hospitalization, as an example. Of course you're going to follow up after. Of course you would. You've got somebody hospitalized for mental illness. You've referred them to the hospital. You may not be the hospital, and they get out. The success of their being out is dependent on that contact with the agency when they're done, to provide the follow-up care that's necessary, to provide the monitoring, to provide the contact that is necessary to keep people out of the hospital. It is the goal of most every mental health agency I've ever dealt with, as well as the Excellence in Mental Health Act, to keep people out of a hospital, to keep people in the least intrusive level of care possible, both for cost and for practice. And I can say for cost, and people can say, well, we don't, that we're just trying to do things on the cheap. But every dollar I save putting somebody in a hospital is a dollar I can put to expanding the programs for everybody. And that's an important context in all of this too, is that these processes should help in the quality of services and the need for services and the demand for services. Follow-up care for children prescribed with ADHD medication. This is one I think that's important too. A child who is giving ADHD medication needs to have follow-up. How is the medication doing? How is the child doing? Once the ADHD is addressed, are there other issues that the child has that now come to the fore because we've controlled that enough to see them? Is the ADHD medication being prescribed by a primary physician, in which case there needs to be integration because some of those issues could be mental health issues. And again, what you're seeing is an absolute, these are called quality measures. These are measures that are looked at by again, PQRS, by CMS for meaningful use, and now by the Excellence in Mental Health Act. And I would state, again, for the nth time, that yes, these are quality measures, and yes, I have to report them. But even if I didn't, how many of these measures are ones that I would say my agency just should ignore? Because what I'm proposing here is that these are measures that shouldn't be ignored, that these are measures that even if you don't have to report them, don't have to change the way that you practice, but can enhance the way you understand the results of your practicing. You're not changing. This isn't telling you to change, but it's giving you the opportunity to see how you might enhance that changing and really improve what happens from it. Cardiovascular health monitoring for people with cardiovascular disease and schizophrenia. And I would even leave the schizophrenia out because everything I've ever read, I'm sure you've ever read about cardiovascular disease, there is a component of mental health in that needs to be addressed if people are really going to be able to benefit from the disease, from any treatment. But here again, when you have these co-occurring diseases, such as a very serious health and a mental health diagnosis, if we put the person in the middle, then what does that person need? They need the professionals on either side to integrate the care, to integrate the conversations, to integrate the interactions, so that we don't expect that the client suffering from these two major illnesses to have to be the one to own that discussion. So again, the concept of integrated care, which is part of Excellence in Mental Health Act and part of what many of you are looking to even outside of the Excellence in Mental Health Act. Health homes, other types of programs. The idea is if we make the patient responsible to go to point A, point B, point C, and point D to get the care, there's lots of problems that could ensue. All those providers may not know what's going on, but the client may not really be able to be the best and sole person to describe the needs and what's important. So this gives you the opportunity to really take a look at those kinds of things. The outcomes measures are really simple. The MISIP probes, many of you probably are familiar with. But if we're going to do in CCBHCs, if we're going to have person-centered and family-centered care, we have to know what the person thinks and what the family thinks of that care. There have been many attempts to implement MISIP across many spectrums that I've seen during my way more years than I like to admit in behavioral health. Sometimes it works, sometimes it doesn't. But the reality is if we don't give people standardized forms to tell us how it's going, how it's doing, we really don't know. Because if it's anecdotal, they may not answer questions honestly. There may be some of my prejudices may enter into how I represent the anecdotal. It is in these items, and these are specifically required by the Excellence in Mental Health Act, that we can really get at, are we doing a good job? Because that's what we all want to do, whether we're a CCBHC or an agency that isn't a CCBHC. What we want to know is that we are doing what our clients, who in essence are our customers, need, and that they feel that the quality of what they're getting meets what they need and meets their or exceeds their expectations. So there's some other items that I think are really important that are part of the Excellence in Mental Health Act. First off, the CCBHCs are required to develop a continuous quality improvement plan. This isn't really a quality measure. This is an internal quality improvement plan. And I would guess that I put this here because it is a quality measure. It's required by CCBHCs, and probably it's something that we should train and help every agency do. Because what it really does is it asks you to look at yourself. Maybe you're looking at the quality measures that we just talked about. Maybe you're looking at some other items, training or staff development or staff turnover or any of those, the kinds of things that speak to the health of your agency, and always looking how we can improve it. The concept of clinical quality improvement is that there's always somewhere to improve. There's always a plan in place to keep making those improvements, and it's an ongoing reference. So we have a plan, we work on that plan, and then we bring it back whole in, and we start looking if we want to modify the plan. And that's not something that it's going to change the way you provide care, nor should it change the way you provide care. But it may change and give you another way of looking at yourself and your own processes and how they're working for both you and then as it extrapolates out for your clients. The next point is, I think, really, really important, and that is that the CCBHC you shouldn't consider that because a specific metric wasn't included, somehow it's not important. If you have metrics that you use, whether you're a CCBHC or not, nobody is saying you can't use them. All that's being suggested is that these are the baselines. And if you have better or more or something that gives you a better idea of what to look for and is more specifically addressing your needs, that's okay too, even if you're a CCBHC. So again, understanding behavioral health this legislation didn't say this is what you must do, because behavioral health is not as predictable in many ways, or as segmented in some, I guess, as planned for, as if I have a heart attack, how I'm going to get treated can be the same across multiple health agencies. But you're not all going to deal with depression the same way, nor is this saying you should. What it's saying is everybody who deals with depression should look at these items, and then if there are other criteria you want to look at, that's fine. Keep doing it and use those, because those are assessments that are valuable for you. So it allows that difference in the ways each of you might do your business currently. Evidence-based practice is another one. Yes, the Excellence in Mental Health Act requires evidence-based treatment. And yes, that's something that it's important that it does. And most every Medicaid program now requires it. Most every behavioral health program uses it. And within the legislation, they describe maybe 9 or 10 options for what those could be. But they don't tell you which one to use, because that, again, they're not telling you how to practice. They're telling you what your practice should include, which is evidence-based programming, evidence-based practices. I'm not sure anyone would disagree with that. I know that in education today, evidence-based practice is a core and a fundamental part of it. Similar in behavioral health. So this is an example of why the Excellence in Mental Health Act is unlike other acts, in that while it does say you have to use it, it doesn't tell you what to use. And as long as it's an accepted evidence-based practice, it's accepted to the CCBHCs. And so it's adopting it as part of your agency, again, whether or not you're a CCBHC, makes sense. And it's really just the concept that you have that is being prescribed, not a method. A couple other things that the CCBHCs are asked to do, but you can do them too. Clinical decision support and electronically transmit prescriptions. I'm guessing most of you send prescriptions electronically now, but if you don't, of course that's going to be part of the practice, because it does allow for a more organized sense of prescribing and of tracking prescriptions and of managing prescriptions. It doesn't tell you what vendor to use. It doesn't tell you how to do it. It just says that we know that prescriptions are going to be quicker, more correct, and better if they're sent electronically. So if you want to be a CCBHC, you're going to send your prescriptions electronically. Probably you're already getting meaningful use, so you do it, but just in case, that gives you that. And clinical decision support. They're not telling you what decisions you should put in there. What they're saying is use clinical decision support, because it provides an extra level of information to your clinicians to help them in the decisions they make. And yes, you can, if clinical decision support is used across the country, then there is another opportunity to ensure a certain continuity of the information that's being given to clinicians, notwithstanding where they're located. So the idea that really has been presented today, and I want to propose, is that the CCBHCs are the first time we know what the federal government is looking for in behavioral health practice. We know because many entities that we work with helped design that legislation. And whether we're going to be a CCBHC, we can learn from it, because we can see what goes on, what they're looking for within the quality measures and the outcome measures. And we can identify those that, if adopted by our agencies, whether or not we're a CCBHC, will not change the way we practice, but may improve the way we look at the data that's collected as part of our practice. And with that, I can go to my last slide, which which is really an opportunity, and I'll turn it back to Julie, for questions.
Great. Sookie, thank you so much for a very informative presentation. We have had a number of questions come in from the audience, but we'd like to remind everyone that you can use that Q&A widget below the slides on your screen to submit a question at any time. So can you give us a little bit of a big picture perspective? Where are we at in the timeline of actually launching CCBHCs? I know this was a project that was going to be rolled out in phases. Are we in the very early stages, or where are we at with this?
Well, the federal government, the feds did, well, SAMHSA did a proposal, accepted grants. There were 24 states selected, of which 8 will become CCBHC states. The first grant was a planning grant. Those decisions for which states will go forward should be made in October, and January should be the start date for the actual CCBHCs. For that October date, though, the CCBHCs in each of those 24 states have to be able to demonstrate that they are ready to start being that entity as of that date. But we really would expect January 1st, with the only proviso that right now in Washington, there are various proposals to extend the number of states to a larger number than 8. And some of you might know, but maybe we're in the middle of an election year, which could cause some disruption of the, I'm not planning for it, but I always accept in election years that there could be some disruption of the planning grants waiting for that other decision to get made.
Okay, great. And someone in our audience is asking, what do you consider as an outcome measure, and what do you consider as a better care measure? Because there is clearly a relationship between the two. Do you have some comments on that?
Well, I think that the outcome measures are going to be ones like, just a second, and I'm doing it right. I think the outcome measures, they're the consumer outcome ones, which are the MISIP, and then I think they're the other outcome measures which speak to things like follow-up care for children who have ADHD. I think that there are some where when it says the number and percent, whenever a measure says number and percent, you're really looking at something that the federal government looks as an outcome, because what they're looking for is what is that percent. When it's not so specific to a number, it may be more of a generalized, this will be an improvement in care. But it's important to mention that each of these items will get reported on as they sit now as part of CCBHC. So whether it's a true quantitative measure or it's going to be made into one, there is a quantitative report that will go out that includes, like, what are your total client numbers, how many with this particular, how many have ADHD, how many had that next checkup, that kind of thing will go out for each of these measures.
That's a really good point. Thank you. And someone in our audience is asking, where can we find a copy of the Medicaid Adult Corset and the Medicaid Child Corset? It's on the internet. I don't have the website with me. Is there a way I can get it to somebody? Julie, can I get it to Chris or to you, and you can post it with the slides or something? Sure, we'd be happy to share.
Okay, I can do.
And in terms of the reporting requirements, are those reporting requirements only going to apply specifically to Medicaid populations, or is it across broader populations? The CCBHCs are being paid for Medicaid, so it's Medicaid eligibles, but there is language that the CCBHC is not allowed to turn anyone away. It is, the reporting will be across whatever population they serve. The initial goal is for them to serve them. It is a Medicaid, it's kind of like a Medicaid waiver, but it's a Medicaid program. But in some states, as an example, the county is doing it, and when a county does it, they're the safety net. So whether it's a CCBHC in a catchment area or a county, it is likely, and the statute anticipates, that there will be non-Medicaid folks who are participating in this, not private insurance, but non-Medicaid. Okay, and do you anticipate that this type of quality data that's being collected might sometime in the future be used for comparisons to compare one provider's quality to another?
If we look at hospitals as the example, then yes, because what was done with hospital data was exactly that. Hospital data was collected and scorecards were given. Nobody has said that's going to get done, but if I look, somebody once told me if I look at what goes on in physical health and I wait 10 years, I'll see it in behavioral health. So I would say that ultimately that kind of information probably will be made available. There's no, that's a tea leaf reading, not a specific provision in the law.
Okay, great. And someone in our audience is asking about decision supports. Do you see decision supports as being applied in relationship to medication, or do you see it being applied for psychosocial intervention, or where do you see these decision supports being applied?
The way that meaningful use required entities to design clinical decision support, it was designed to be used in all of those. So based on diagnosis, based on medication, based on medication and diagnosis, based on dual diagnosis. So it's really, I think it can be as broad-based as the agency wants it to be. A lot of decision support goes out to something like Medline or the National Institutes of Health or some sort of, and the real good thing about clinical decision support is when it goes to a website that is constantly updated so that the newest in medication, the newest in literature, I did one for somebody that had something to do with Alzheimer's because that literature changes, or Parkinson's, the literature changes all the time, and those are really when you want clinical decision support. The other way to do clinical decision support, and this is agency-based, is if you have practices within your agency that you expect to be adhered to specifically, then you can link them to an intranet site that's internal to your agency. But as far as how, it's really going to be up to the agency, and I think it's all of the above.
Okay, great. And what do you think might be one top challenge for CCBHCs in practice? What might be a top challenge for them?
Well, I decided today I was going to stay away from the finance side of it, so I'm not going to say that. I think it's really going to be most every CCBHC that I've talked to has never dealt with a catchment area quite as broad as they're about to deal with as many languages, with as many differentiations as what they're about to get into. And I think it's going to be a challenge. The other piece that I think is a huge challenge for most agencies, it is prescribed by CCBHC that you bring that quality information down to the provider level. Most agencies keep it at the agency level now. Quality, the quality concepts, outcomes. It is the program managers that know it, the clinical directors. It is required now, and you'll get looked at, that information gets put into the hands of the clinician so it can be immediately brought back into their practices. And I think that's going to be a real change in management structures, which I think is a challenge for a lot of agencies.
Okay, great. That is really good information. Unfortunately, that is all the time that we have for questions today. But again, I'd like to thank Sookie Norris for an excellent presentation. I would also like to thank our sponsor today, Echo Group, for making today's program possible. And finally, thank you to everyone in our audience for participating today. We do hope that you'll join us again in the future for another behavioral healthcare webinar. This concludes today's presentation. Good afternoon, and welcome to today's program, Treating for Outcomes or Better Care, Understanding the Excellence in Mental Health Act. I'm Julie Miller, Editor-in-Chief of Behavioral Healthcare. Today's program is sponsored by Echo Group. Thank you to our sponsor and to everyone in our audience for giving us your time and attention today. Before we get started, we do have a few details that we would like to review.